Welcome everybody to the Pacific Spine and Pain Society webinar on intradiscal therapeutics. My name is Ramo Naidu and I'll be your moderator for tonight. We know that a few of you will be straggling in over the next few minutes, so I'm going to start out just by talking about tonight's webinar, and then we'll get into the meat of our discussion. So for me personally, this particular discussion has been really important for me over the last 10 years since being in practice as an interventional pain physician. To be really blunt, when I was a fellow in 2011, I hardly got any exposure to intradiscal therapeutics. And basically everything I was doing was addressing the posterior elements or the intraspinal elements of the spine. And we weren't really doing a whole lot for the anterior columns. And quite frankly, in our fellowship, we weren't doing kyphoplasty because the IR group was doing it at UCSF. So I really didn't get that side of the spine as a fellow. And since being in private practice, I have really understood that I am really missing out on a lot of the conditions of the spine that really need amelioration. And what I've learned is that there's been this roller coaster history when it comes to intradiscal diagnostics as well as therapeutics. And over the last few years, we have been fortunate enough to see a huge blossoming of a lot of the therapies that are, again, trying to address what we've known as discogenic pain. So hopefully tonight you're going to hear from some of the world's experts on this particular topic, understand where we've been, what's been going on over the last 10 years and where we're going, and I'll look forward to introducing everyone. The disc, as we all know, is a very sacred structure in the human body. You know its anatomy very well, but in many ways we still don't understand exactly how to tame this beast. Next slide. So our disclosures for tonight are as follows. I'll just pause for just a moment so everyone can absorb that. Next slide. And I'd like to give a special thank you to our sponsors of this event, Regeltech, Spine Biopharma, and Vivex Biologics. Without their support, we wouldn't be able to put on this webinar, and we look forward to hearing about some of the data that these companies have been working on over the last few years. Next slide. So I want to start out by framing our discussion for tonight. What I've noticed when I was teaching at UCSF for a few years, and then especially going out into private practice over the last 6 years, is that there has been a divide generationally in those who are doing intradiscal therapeutics. And quite frankly, if you talk to some of the guys who are, in their upper 40s or older or retired, they've been doing intradiscal stuff, for most of their careers, with some successes and some failures and everything in between. But when you talk to the younger generation, including myself, those that are, my age or younger, who are basically within 10 years of fellowship, you don't see a lot of people doing intradiscal. And a big part of that is this risk-benefit balance. And what we've seen is, of course, some of the reimbursement that's overhanging that risk-benefit balance, which has shifted us away from even doing any procedures within the disc. And that unfortunately has led to, I think, a drought in innovation, a drought in understanding of the anterior lumbar spine especially. And again, why I'm excited about some of the new therapies that are coming out and the evidence we're developing is we need to see if we're missing out on something that can be really beneficial for our patients, some of whom who either rely on opioid medications or go have a surgery that is quite invasive with a long recovery. Some of these minimally invasive options may offer some hope. So what we're going to go through tonight is really how that seesaw has changed over the last 50 years or 60 years in intradiscal therapeutics. Some of you might be thinking in the back of your head, well, I don't do this stuff because I'm so worried about discitis. Dr. Davis is going to go through complications and how we've kind of overblown a lot of that thought and how we try to mitigate those risks. Not to say they don't occur, but really how we've amplified it in our minds and how we can, again, mitigate and attack these issues. And then we'll talk more about the benefits, the potential benefits, and where some therapies have come and gone. Dr. Derby, who we're really privileged to have tonight, is going to go through some of his own personal history. And so I'm looking forward to hearing everybody's talk tonight. Next slide. So without further ado, I'd like to introduce our faculty. As I mentioned, my name is Ramo Naidu. I live in Marin County, just north of San Francisco. I've been in private practice, as I mentioned, for 6 years. I was doing anesthesia. I did my anesthesiology training at the University of Washington in Seattle, then did my fellowship at University of California, San Francisco for a year, where I worked with a lot of well-known people, stayed on board as faculty for 5 years, and then jumped across. Our first speaker, I'm really privileged, as I mentioned, to introduce is Dr. Rick Derby, or Richard Derby. He's an anesthesiologist and interventionalist with over 40 years of experience and 120 publications in the field of image-guided diagnostic and therapeutic procedures for spine-related pain. Rick lives just down the way in Tiburon, which is not far from where I am, just a few miles. And so I was really privileged to, again, grab him for this particular webinar. And everywhere I've gone over the last few years, when we talk about intradiscal stuff, a lot of people mention his name. So again, he's had tremendous experience. Rick recently retired and continues to publish and participate in the spine and interventional pain fields as a speaker and board member of the Spine Intervention Society, a society he co-founded in 1992. Their annual meeting is in middle September, September 15th through 18th in Vancouver, Canada. It unfortunately coincides with our own annual meeting, the Pacific Spine and Pain Society meeting, which is in Las Vegas. And so I know some of the individuals might be going back and forth between Vancouver and Las Vegas for both meetings. And we hope those of you who are on the webinar tonight will be joining us for the PSPS annual meeting in Vegas. Dr. Kazra Amir Delfin, a good friend of mine, Vice President on Business Development and the Director of Clinical Research at IPM Medical Group, not too far away from me as well, across one of the bridges in the Bay Area in Walnut Creek, California. He received his medical degree from Texas A&M, completed his residency at John Peter Smith Hospital in Fort Worth, Texas, and which is affiliated with UT Southwestern. And then he went on to do a very, very intriguing fellowship in interventional pain medicine with a well-known leader in neuromodulation, Dr. Elliot Crames in San Francisco. He is regarded as one of the foremost global key opinion leaders in the field of interventional pain management and neuromodulation, and is a lead author in many of our major spinal cord stimulation randomized controlled trials over the past 7 years. He is also one of the co-founders of Pacific Spine and Pain Society. Dr. Tim Davis is board certified in physical medicine, rehabilitation, and pain medicine. He is the founder of Source Healthcare, Source Surgery Center, and Bluebird Corporation. He is absolutely an expert in spine and musculoskeletal disorders and has performed extensive research using biological therapies for spine and joint surgeries. He's also super cool. And last but certainly not least is Dr. Douglas Beal, who attended medical school at Georgetown University, School of Medicine in Washington, D.C., completed his residency at the Johns Hopkins Hospital in Baltimore, Maryland, never heard of them. He then completed a fellowship in musculoskeletal radiology at Mayo in Rochester, Minnesota, also never heard of them. Then went on to enter the U.S. Air Force and Division Chief of Musculoskeletal Radiology there, where he was the fellowship director and at the University of Oklahoma prior to entering private practice, where he was the chief of services. He is board certified in diagnostic radiology and then added the fellowship in musculoskeletal radiology. He's a diplomat of the American Academy of Pain Management as a fellow of the Society of Interventional Radiology and Interventional Pain Practice. He's board certified as well by the World Institute of Pain. So as you can see from our panel, we have a diverse group of individuals with various residency trainings and fellowship backgrounds, all with extensive experience in intradiscal therapeutics. Thank you so much, Dr. Derby. I'm going to hand it off to you. Take it away. And here's our agenda before Dr. Derby jumps on. He's going to start off talking about the history of intradiscal therapies. Dr. Amir Delfin will talk about the intradiscal therapies evidence, which is so important. PSPS prides itself on its evidence development and understanding. Then Dr. Davis will talk about complications associated with intradiscal therapies. And again, Dr. Beal will talk about the future landscape of intradiscal therapies. Now, Dr. Derby, take it away. Thank you so much.
Okay, just a second. All right, share my webcam. Are we on now? Hello?
We're on. You take it away, my friend.
Okay. Well, thank you, Ramo, for inviting me. It really is an honor. As an old retired fart, I certainly don't like to miss any opportunity to speak. Next slide. Next slide, thank you. And for this talk, I really have nothing to disclose. We began using precision image-guided procedures in the 1970s with an incomplete understanding of spine degeneration and suboptimal tools. Today, our tools and techniques are much better, our understanding more complete. And although I anticipate exciting future breakthroughs, next slide, the interventional diagnosis and treatment of discogenic pain is still our most difficult unresolved challenge. We rode and continue to ride an excitement curtailment procedure roller coaster. We enthusiastically embrace new procedures and devices that with exponential utilization result in mean outcomes straddling the 50% effectiveness barrier. Most past procedures have dwindled into obscurity, as a disc is arguably the most common direct and indirect source of recurring spinal pain. It is imperative that both our diagnostic and treatment options evolve. Next slide. Diagnosing and reliably assessing treatment outcome for discogenic pain is challenging because pain intensity cycles between acute chemically induced and a chronic mechanically maintained state. Next slide. Nuclear fragments, a consequence of degeneration and injury, are reabsorbed by resident chondrocytes. Matrix breakdown products called danger-associated molecular particles, or DAMPs, activate toll-like receptors on cell membranes that in turn activate target cell inflammatory apoptotic pathways. This innate immune system stimulation causes increased density and sensitization nociceptive fibers. Unhealed fissures and end plates allow and maintain the unobstructed digression of inflammatory chemicals to adjacent innervated structures. Next slide. Decreased disc height promotes segmental instability and localized deformity. Swelling of unrestrained nuclear fragments within outer annular tears cause increased tensional loads on a sensitized outer annulus. Next slide. Our first interventional device to treat discogenic pain used heat to promote regeneration, strengthening, and denervation of the annulus. Menno Schloiter heated the nucleus using a radiofrequency needle. I modified his technique in 1995 to heat the outer posterior annulus, developed by the Sahlbarths, who are local, and actually one of my past partners. IDET used a heated flexible cannula. While heating the annulus was beneficial to many patients, the technique failed to consistently provide pain relief, in part perhaps due to inadequate annular denervation, inability to remove stressed nuclear fragments, and in retrospect, continued pain from the end plates. Next slide. Despite device improvements, including a shorter heating length to focus treatment, cool heating techniques to cover larger areas, and the addition of complementary procedures like sealing the annular tear immediately after heating, the high prevalence of discogenic pain and a growing number of interventionalists resulted in escalating utilization without demonstrable payer benefit, thus payer curtailment. Next slide. Could you go back? Yeah, I had a fade in. Likewise, we base small cannula interventional nuclear decompression on an incomplete understanding of causation. While minimal decompression may reduce pressure and favorably alter cytokine expression, disc pressure in the majority of cases is already low, and fragment ablation is minimal within annular tears. And again, moreover, end plate pain remains. Now next. Our early intradiscal solutions included patient-derived injectates, in quotes, regenerative solutions, neurolytic solutions, anti-inflammatory solutions, and scaffolding filler injectates. Next slide. Anecdotally, sealing the outer annular tear with fibrin may have facilitated favorable outcome in selected patients. Next slide. Sealants may act as a scaffold to promote annular repair. Improved sealants could also potentially bind slow release regenerative solutions to enhance and prolong annular healing. Next slide. To improve our inconsistent outcomes using minimally invasive intradiscal devices, in the early 2000s, we used a regenerative solution developed by my associate, Dr. Bjorn Eck. Next slide. Although animal studies showed a positive effect and our observational audits found statistical pain improvement, the clinical improvement, especially long-term, was less robust. Like other early injectates, steroids, methylene blue, ozone, etc., these early injectables would, in my opinion, not survive randomized trials. Next slide. On the other hand, patient satisfaction was considerably better than iDet or nucleoplasty. This is the attraction of most injectable restorative disc solutions. They are relatively straightforward to do, relatively atraumatic, relatively inexpensive, and except for infection, relatively benign. And patient satisfaction is mostly favorable. Next slide. So to conclude, although we are currently unable to diagnostically separate discogenic pain from end-plate vertebral body pain, which, as you all know, is transmitted by the base vertebral nerve, discogenic pain transmitted by the sinovertebral nerve within annular tears and adjacent structures may be reduced following arthroscopic nuclear fragment removal as the products of matrix reabsorption and chondrocyte apoptosis initiate and maintain neural irritability. Injectable biologics and scaffolds may help annular tear closure, perhaps end plate repair, and perhaps limited annular and matrix repair in discs with limited damage. Regenerating normal disc architecture will be challenging. However, removing nuclear debris, sealing annular tears, and facilitating wound closure with connective tissue is perhaps a more realistic near-term goal. Thank you so much for your attention.
All right, thank you so much, Dr. Derby. That was amazing. And good evening, everyone. My name is Cass Amert-Delphin. I'm an interventional pain physician in Northern California. And my section is all about the emerging evidence in intradiscal therapies. Before I get started, I just want to thank Pacific Spine and Pain Society for having webinars like this and the level of education that this society has been providing for all its members in the western region of the United States. I want to personally thank Dr. Naidu for his presidency and his commitment to the society. And it's an honor to be here with the likes of Dr. Derby, Dr. Beal, and Dr. Davis to go through these. With that, I'm going to jump into the evidence that we have so far. Next slide, please. So axial low back pain continues to be one of the biggest problems that we see in our practices every day. And it just so happens that degenerative disc disease continues to be a major cause of axial low back pain for our patient population. Next. Maybe I should take control of the slides. Let's see, will I be able to control it? So that way it'll be a little bit easier. If you can give me control, then I'll take over. But really, there's been a lot of different manufacturers that have paid a lot of attention to treating lumbar degenerative disc disease and axial low back pain. One of them that's really near and dear to me is Mesoblast. It's a manufacturer out of Australia. And the reason for that is it was one of the very first stem cell studies that I performed at our centers in Walnut Creek in Northern California. Dr. Tim Davis was the one who introduced me to that team, and he and I were both involved in that study. And since then, Dr. Beal, Dr. Davis, and I have continued to work with this manufacturer. What they developed is an allogeneic strain of mesenchymal precursor stem cells, which they're called rexlemestrocel L, and really what these MPCs do is that they get activated by multiple inflammatory cytokines, and they orchestrate an anti-inflammatory cascade within the disc itself. Next slide. We did a safety and efficacy study a few years ago on about 100 patients at 10 sites. It was a single-blinded multi-arm study, and that study showed that this product is not only safe, but it can also be efficacious in producing some significant axial low back pain relief for the patient population. We published that 36-month study in the Journal of Spine. I happen to be the primary author on that paper, but that brought us to a phase 3 study that was just recently completed with about 404 patients. This study with the rexlemestrocel used 6 million mesenchymal precursor stem cells mixed 1-to-1 with hyaluronic acid, or the MPC cells 6 million without the hyaluronic acid, or the placebo or the control, which is saline. Now, everybody on this call will tell you that saline may be a control, but it is not a placebo. For a lot of different reasons, saline does have some effect on the disc itself, and it does give us some results as well. Next slide. The details of this study have not been published yet. This is from their press release. We've seen a lot more data than I'm about to show you here, but suffice it to say that we know that the MPCs, along with the hyaluronic acids, at 6 million cells of the MPCs with the HA vehicle, gives the patients the most significant pain relief. The rexlemestrocel by itself does also provide the patients with some pain relief, as it does the control and the saline. But clearly, the hyaluronic acid and the rexlemestrocel work far better to get a reduction of the patient's low back pain. Next slide. Aside from that, the quality of life for the patients using the rexlemestrocel and the hyaluronic acid was far improved than the cells themselves and versus the control. As you can see, this data is through 36 months, so this is long-term data with a single injection of this product. Next slide. Now we move on to Dysgenics, which is a really interesting product. The manufacturer has been working on the product here for some time. They're centered in Utah, and I've gotten to know the company and the product really well over the last few years. And next slide. What they have is discogenic cells that are thought to be regenerative by producing extracellular matrix in the patients that get this type of injection. Next slide. Aside from that, we know that this discogenic cells can also have an anti-inflammatory effect. These have been shown in vitro. As you can see here, the mixed lymphocyte reaction was reduced significantly in several different studies using 2 different strains of these discogenic cells. Next slide. So these cells are actually called disc progenitor cells that are really derived from human tissue. The preclinical studies showed improved disc height by an architecture in animal models. That was also shown in mesoblasts, but we didn't really see it actively in our human patient population. So we think that this product can potentially positively impact the pathophysiology of lumbar degenerative disc disease. But in order to be able to understand it better, obviously some human studies needed to be done. There's a safety and preliminary efficacy study on their way. This is a 104-week study. The 78-week data is available. It's been presented at a lot of different prestigious meetings, but I have a glimpse of what this data looks like for us right now. Next slide. As you can see, the blue line, which is the high dose of these progenitor cells, gave the patients the most significant pain relief. The vehicle itself, the placebo, and the low dose also had a respectable showing as well. This is something that we would expect along the way, but the clear winner here through the 78 weeks is the high dose injection of these progenitor cells. Next slide. And if you look at the amount of improvement, the high dose cells gave us twice the minimal clinical important difference of improvement in the VAS scores. That's really significant versus the placebo the vehicle and the low-dose product. Next slide. So in ODI scores, Osteoarthritis Disability Index scores, again, all cohorts showed us some improvement in their function, but the clear winner was once again the high-dose product, showing us 3 times the MCID improvement for that patient population from the baseline through 78 weeks with 1 single injection, and that's really significant. Next slide. And as you can see, the quality of life based on the EQ5D showed some significant improvement, 3 times the MCID as well, versus the other product and the placebo and control as well. Next slide. Now let's talk about Biodisc NP. Biodisc NP is really the only product that's commercially available for use here in the United States, and we're going to get into this product a little bit more in the next slide. So this is nucleus pulposus, and it's designed to mimic healthy nucleus pulposus. It basically, as most of you know, 80% of nucleus pulposus is actually water weight, and it's the hydration that gives the disc the kind of integrity that it needs. The nucleus pulposus product is a dry particulate allograft. We call it micronized NP, and it can be reconstituted with saline in order for it to have the original water content before injection into the nucleus itself. This preserves the proteoglycan structure, and it can potentially absorb water and help improve the hydrostatic properties of the disc itself. The hydrostatic support and the hydration increases the physical integrity of the disc and the ability for it to resist compression, and it cushions the axial load. Next slide. But does it really work? The nucleus pulposus itself had never been studied before. And this is the reason why the manufacturer of this particular product, Vivex Laboratories, decided to do a prospective, open label, single arm multi-center study that Dr. Davis, Dr. Bila, and I were all involved in. I believe Dr. Naidu was involved in that study as well. The complete results are not out yet, but the early results for site number 1 is available, and I'm going to share that with you. This was a 35 patient pilot study, and there's a little background to this. We actually, go back to that, there you go. We actually did a 12-month study using the nucleus pulposus product. Next slide, please. Along with cellular tissue. So we used cellular tissue along with the nucleus pulposus and injected certain lumbar discs for the patients. And what we were able to show with that particular study was that we not only did not have any severe adverse events, but there was significant improvement in the patient's FAST scores and Osteoarthritis Disability Index scores. That study has been published at this point, but as you know, using cellular products here in the United States is still on hold by the FDA, and it needs additional studies. Vivex Laboratories is no exception. This is the reason why the manufacturer and the investigators, along with the scientific advisory board, thought whether we could actually use the nucleus pulposus itself and what kind of results would we get if the injection was just the NP itself. Next slide. As I said, this is very early data. On the left side of this slide, you can see site number 1's data from the VAST study, which was the nucleus pulposus along with the cellular tissue. And as you can see, there was a 77% reduction in patients' low back pain based on the VAST scores that they reported in this one site for the 12 subjects that were in this particular site. This happens to be Dr. Beal's site, by the way. So you know that it's a reputable site. Looking on the right side with the NP pilot study, you can see how the 3-month data shows an impressive 70% reduction just using nucleus pulposus by itself. Is this the panacea? We don't know, but this is a step in the right direction, especially since this product is actually available for us to be able to use with a T code that has been granted to it. Next slide. Based on the ODI scores, there was significant improvement in the patient's level of function. Again, with the VAST study, which included cellular tissue, with 67% improvement in the patient's ODI scores, versus at the 3-month mark with the 5 subjects in this same site using nucleus pulposus alone, who showed a 70% improvement in the ODI scores that they reported. So the results seem to be comparable, but again, we need to get all the data and follow these patients for a full 12 months for us to be able to understand the outcomes better. Next slide. So the key points are, it's commercially available. It's a mechanical supplementation and cushioning of the disc itself. There's been over 1,000 cases performed to date, and it's the same nucleus pulposus tissue that the ViaDisc product had in the VAST study that we did a couple of years ago. The safety profile has been established, although there's some nuances to that. Tim Davis will get into that in a little bit more detail. But we need to build the clinical evidence with this. Next slide. Spine Biopharma, it's an investigational product. Next slide. This is a 7 amino acid synthetic peptide, which is derived from conserved regions of the disc matrix itself. It contains, this product actually antagonizes tumor growth factor beta 1. So it's an antagonist of that product, and it can be done with a single injection. The hope is that it can actually be therapeutic for 6 months at a time, and obviously it can be done in the office or at a surgery center. Next slide. The SP1 product is thought to have a dual mechanism of action. It can be anti-inflammatory for the neuromodulation of the pain, and is thought to produce some extracellular matrix and regeneration of the disc itself. Next slide. The preliminary data has been really promising. A phase 3 study just got underway in April of this year. Our friend Dr. Chris Gilligan is the primary investigator of this study. This is going to be a multi-center, randomized, double-blind, placebo-controlled study, and we're all excited to see the results of this particular study as well. Next slide. So far we've talked about human tissue, stem cells, nucleus pulposus, that in order for us to be able to help at least reduce the patient's pain and to some extent maybe regenerate the matrix of the disc itself and provide integrity. But outside of that, there's a synthetic product that really needs to be mentioned as well. This product is by a manufacturer called Regeltech. It's called Hydrofil. Next slide. This is also an investigational product, and it's not FDA approved yet. But this is an ASC-based or office-based injectable product, which is thought to restore the natural biomechanics of the disc. Prior to the injection, the product is heated up, it becomes liquid, and you can very easily inject it through a disc. You can treat 1 or 2 lumbar discs with it. We think that it could potentially seal the annulus, increase the volume, and return some hydration to the disc by creating some of the hydrophilic properties, because the product itself is hydrophilic. The product is durable and inert, and in vitro studies showed that 20 years of simulated wear and tear only had minimal wear on the Hydrofil product itself. Next slide. So despite the fact that the studies in the United States have not gotten underway, they're still in the planning stages. 3 different cohorts of patients have been treated in Canada and in Colombia. As you can see on the right side, most of these patients, understandably, were L4-5 and L5S1 disc patients, and the belly of the bell curve for the modified Perman scores was 5, although we think that we can actually treat modified Perman score all the way up to 8 with this product. The difference is with the nucleus pulposus and the stem cell products, we're going after mild to moderate degenerative disc disease. This product may be appropriate for moderate to severe degenerative disc disease. You can see the inclusion-exclusion criteria right there. Next slide. And as you can see, in every single cohort, there was a significant reduction in the patient's NRS score. In the patients in cohort 2 and 3, the reduction in the score went all the way to 1 at the 3-month mark. But you know, the cohort that has gone all the way to 1 year with the 19 subjects had a very respectable showing with the baseline pain of about 7 being reduced down to about 2. But the other 2 are doing really well as well. Next slide. It's important to understand that all these patients will be followed all the way through 12 months and beyond, because we need to understand this product better, about its longevity and the way it can really provide the integrity to the disc and improve the patient's pain. And you can see how the patient's pain scores were, the ODI scores were also improved significantly. Again, all of these fall in par with each other, with the longest cohort, the cohort 1, having been followed all the way through 12 months with 19 subjects. You can see how the ODI scores improved to the minimal level in every single cohort that have been studied so far. Very, very promising. Next slide. These are flexion and extension x-rays of a patient who got hydrogel injection at 2 different levels. You can see the flexion and extension x-rays at 30 days and followed at 180 days. There's virtually no difference between these x-rays at all. Next slide. So in conclusion, there's promising new regenerative and restorative products on the horizon. There's evolving evidence which will help us determine which one of these products is actually going to be the right choice for our patients. And it's going to make us better diagnosticians as we understand the anatomy of the disc better and how we should treat our patient population. Appropriate candidates may have more than one product available to them on the market, and the future will show us additional regenerative and integrative choices that could potentially treat our patients and reduce the number of surgical interventions in the patients. Thank you. Next slide. There you go. Dr. Davis.
Hey, I'll go ahead and advance on myself. So I'm going to be talking about the complications of these intradiscal therapies. We've been doing a lot of these biologic studies over the past 16, 17 years. And so doing enough of these things, we start to see these one-off types of reactions, but then over time, we started to see some commonalities in these. And so I'm going to present some of what we've seen throughout all these different studies we've done. Next slide. Anytime you're injecting with intradiscal biologics, usually what's going to happen is there'll be some pain with the initial injection. Usually you're only putting in 1 to 2 cc's of material. Less than 1 cc causes minimal pressure, if any. If it's a painful disc, you'll start to stimulate the annulus, put a little pressure on the end plates, and usually the reaction is some spasm. The body's trying to immobilize the injured level. If you pre-medicate with cyclobenzaprine before the procedure, you can usually avoid that spasm, and so that helps. Pain from the pressurization, depending on how much volume you put in, can last for up to 1 to 2 weeks, but usually will dissipate within the first few days. A lumbar corset can also help with that initial pain. Once again, post-op, muscle relaxants, and then analgesic pains and analgesic pain medication if you need it. Now, secondary pain, that's what we're more concerned about. You can see infection and you can see inflammatory modic changes, and these kind of vary as far as their presentation, but those are the things that you need to be aware of, and those are the things that inevitably, if you do enough of these, you'll end up seeing something like this. Next slide. Next slide. Oh. So this is back from, yep, no, go back, please. Back in 2019, there was a study we did that was with Stryker Biologics. The product was called OP1. What it was bone morphogenetic protein 7, BMP7. This is a protein that naturally occurs in the body when long bone fractures occur. And what it does is it cleans up the prickly ends of a fractured long bone using osteoclast activity, and then stimulates osteoblast activity to start growing back together. Well, in some animal studies, we saw that this also could help to grow cartilage. And so the idea was we put in the nucleus pulposus and try to get it to grow some cartilage. The study overarchingly, failed to show statistical significance against saline. And now we know, this is one of the very early studies, now we know saline does not really act like a placebo. So it failed for the same reasons that many of these other studies have failed, because saline actually has some sort of therapeutic effect. But anyway, this guy, 44-year-old male, 10 to 15 years history of low back pain. He had L4-5 discogenic back pain, study drug injection at the L4-5 level. About 7 weeks post-injection, started to have increased axial back pain. MRI showed L4-5 end plate edema. The labs were all negative. I actually biopsied the discs using a Stryker decompressor to pull out a little nucleus pulposus, and that was completely negative as well. Now, this all resolved by 24 weeks, but I want to show you what gave me some sleepless nights during that time. Next slide. This was the initial MRI that we saw. So you see these inflammatory modic changes above and below the disc level that was injected. And immediately we start thinking it's infectious. Next slide. This is the CAT scan. This is where I really started to lose some sleep. You see osteoclast activity occurring. Now, one thing that, once again, this was the first time we ever saw this. And so BMP7 was actually doing what it was designed to do. It was starting with osteoclast activity and eroding up through the central aspect of the end plate, getting into the vertebral body. I was afraid it was actually going to collapse, but we were still worried that this was an infectious process this time. Next slide. So here's an MRI on the left-hand side and then the CT on the right-hand side. These are axial cuts, and so you can see what it looked like it was basically fluid filled into the cavity that the osteoclast had created. And there's the CAT scan on the right-hand side. Next slide. Now, once again, about this time, this is when I biopsied it. Biopsy was negative. We had no increase in CBC, C-reactive protein, or ESR. So this was an inflammatory modic change that was caused by the biologic that was injected. It was non-infectious. Now, in 2010, we were doing some off-label fibrin sealant. Dr. Derby had mentioned some of that earlier. So this was one of the things that we were testing as well. And so we were doing some of these off-label prior to the study that we eventually ended up getting involved in. And this is a 56-year-old female, 6-year history of low back pain. She had L3-4 and L4-5 discogenic back pain that was validated by provocative discogram. Injected fibrin sealant into both of those levels. About 2 weeks post-op, started to have severe increase in low back pain. She was admitted to the hospital through the emergency department, had in-plate edema at L3-4, one of the levels that was treated. Labs were negative, but then we biopsied it and it was positive. She got IV antibiotics for 6 weeks and the infection completely resolved and her back pain resolved below baseline. So next slide. This is all it looked like. She started to have a little Schmorl's node develop after the injection of the fibrin sealant. The right-hand side is when I did the biopsy and pulled out some nucleus pulposus, and that was what ended up being positive. Her blood cultures were negative, however. Next slide. In 2011, this was Biostat. This was fibrin sealant from the randomized clinical trial, and this was a 23-year-old male with a 5-year history of low back pain, L5S1 discogenic back pain. Ended up getting the fibrin sealant, or Biostat was the brand. It was a company called Spinal Restorations. 2 weeks post-procedure, symptomatically he was better. 16 weeks post-procedure, started to have increased axial low back pain, severe decrease in range of motion with spasm, did an MRI, had in-plate edema and vertebral body edema at L5S1. Labs were negative, blood cultures were negative, and then the biopsy was negative as well. CAT scan showed in-plate erosions. 8 months post, the MRI had improved, and then about 10.5 months post, the pain had reduced below baseline levels. Next slide. So once again, now you're getting to experience my roller coaster of anxiety as we were doing these studies, because in the first one, we thought for sure it was infectious. We did the whole workup, it wasn't infectious, it was self-contained, self-limited, self-resolved. Second one, I'm thinking, okay, maybe this is similar to what it was. No, I was wrong, it was truly infectious. Third one, now I'm gun shy again. I'm like, this has got to be infectious. I do a biopsy, completely negative. This was an inflammatory modic change because of the biologic. So just fibrin sealant alone had stimulated a biologic reaction and caused this type of inflammatory response. Next slide. So here's axial images of the bottom of L5 and the superior aspect of S1. And once again, you can see some similarities to what we saw in the OP1. You got this bullet hole type of style that's right in the center of the end plate. And now that is the thinnest part of the cartilage of the end plate. that is where all the nutrients flow through. And that is where the basovertebral neural network enters, or at least passes through. Next, passes nutrients through. Here's the CT. So once again, you see the end plate erosion, just like we saw back on the OP1. The OP1 study. Next slide. And then here's the axials as well, L5 and S1. Next. In 2012, this was an allogeneic stem cell study. This was actually from the Mesoblast phase 2, I believe is what it was. So this was a 19-year-old male, 2-year history of low back pain, dysgenic low back pain, L5S1 intradiscal study injection. 4 weeks post-op, started to have severe increase in axial low back pain. So now you start putting this all together, and I saw one that was inflammatory motor changes, saw another one that was infectious. The next one was inflammatory motor changes. And so now I have no idea what this is going to be at this point in time, but once again, I'm losing sleep. Decreased range of motion, spasm, MRI showed mild focal end plate edema. So labs were negative at this time. So what did I do? I sat on it for just a little while because I thought that I might be dealing with a similar thing to what I had just seen with the Bioset study. 6 weeks, MRI had increased end plate edema, evolution of Smorl's nodes, and then pop positive. ESR popped up, CRP, white blood count, and then blood cultures were positive. And I biopsied the disc, once again using the Stryker decompressor, and got some tissue, and it popped positive. 6 weeks of IV antibiotics, about 25 weeks post procedure, it all returned back to baseline. Now, one thing that I will tell you is when I did the biopsies of these discs, I flushed it with Vanco after I did the biopsy. So in a couple of cases, they were positive, and probably flushing with Vanco helped to go ahead and reduce that infectious process, as well as along with the IV antibiotics. In a couple of them, we grew out absolutely nothing, and it was an inflammatory response to the biologic. Next. I had some pictures in there of this one. Oh no, I do. Okay, so this is actually a continuation of this. We unblinded this guy, and he had gotten 18 million MFCs, but he was infected. Go to the next slide, and it'll show you the MRI. So that was the T2 sagittal. Go to the next slide. Maybe it's the next one that shows it. Oh, that was pre-treatment. So the last one you just saw was pre-treatment. This was the discitis. And so you can see on the left-hand side in the T1, you can see that end plate edema, and then on the STIR on the right-hand side, you can see some end plate edema as well, and brightening of that nucleus pulposus. So it's a STIR image, and then the previous one was a flare, but type of T1. So next slide. And here's the axials of the entry end plate of L5, and then the axial of the disc at L5S1. Next slide. Now this is 2018, so we fast forward a little bit, and this is a nucleus pulposus allograft with allogeneic stem cells, all right? This is a 44-year-old, 2-year history, low back pain, L1, 2, and L4, 5 were injected. Initial increase in low back pain about 8 weeks after the injection, right? So MRI showed end plate edema, evolution of Smorl's nodes, ESR, CRP, CBC, all within normal limits. This all normalized after about 13 and a half months. Next slide. And so what you'll see is these are sequential. You can see right in the middle, you start to see some pretty significant end plate edema at L1, 2, and L4, 5. And then as you move over to the right, now the Smorl's nodes have really started to show up. But then as you get further on, you can see L4, 5 completely resolves and fills back in. L1-2 actually stayed brighter and hotter for a period of time, but neither one of these was infectious. They sat on it and it went ahead and resolved. Next slide. 2022, nucleus pulposus allograft, 33-year-old male, borderline diabetic, axial low back pain for 3 years. Nucleus pulposus alone injected, 6 weeks post-procedure, increased pain. 12 weeks, MRI showed in-plate edema, ESR, CRP, CBC within normal limits. 24 weeks later, the MRI improved. And this guy had a couple level involvement, but one of them was the one that really lit up. And so this you'll see at the L3-4 level. This is just nucleus pulposus. This is a reaction of the body to nucleus pulposus, and it's non-infectious. So I want you to take a visual picture of this right now, and then I'm going to show you one that looks damn near exactly the same that is infectious. Next slide. So once again, this completely resolved, no treatment. 40-year-old female, L3-4 discogram, 2-needle technique, increased pain within 24 hours after the procedure. 2 weeks post-procedure, L3-4 in-plate edema. Also CT showed erosion, labs were positive, blood cultures were positive. 6 weeks later, she had irrigation debridement and lumbar fusion. Next slide. Looking pretty familiar, huh? So the L3-4 level above and below, you can see the edema showing. Next slide. And then think about what you just saw with the nucleus pulposus, where you had that massive amount of vertebral body and in-plate edema with Schmorl's nodes being created that was completely aseptic and just a biologic reaction. And now this one is completely infectious and an infectious discitis. Next slide. And there's the CT with the in-plate erosion. Next slide. So this is kind of a little summary I put together. OP1, there were 160, I believe, subjects in that study. There was only one of these that we know of, and it was about 8 weeks afterwards, acute onset of axial low back pain. There was this biologic kind of flare, inflammatory modic change. And all we did was we waited and watched. Now, obviously, I did biopsy it. We did check the labs, but everything was negative, and it resolved by about 24 weeks. GDF5, that was a growth differentiation factor 5. There were 150 subjects enrolled. We didn't see anything like this. To seal, this was off-label fibrin sealant. About 6 weeks out, discitis, positive blood cultures, treated with antibiotics, and biopsied it and flushed it, and it was resolved within 16 weeks. Biostat, there were, I think, 210, about 16 weeks out. This one was really weird because a full 4 months out before we saw this biologic type of flare. And once again, negative biopsy, negative labs, negative blood cultures, and we just waited and watched, and it resolved by 43 weeks. MSCs, this was the phase 2 mesoblast. That discitis started to show its ugly head at about 4 weeks. Really declared itself at 6 weeks, and that's when everything started to pop positive. Treated with IV antibiotics and resolved by 25 weeks. Viadisc plus cells, 8 weeks out, there was a flare reaction. Wait, watch, didn't biopsy, but all the labs were negative and resolved by about 24 weeks. Viadisc NP, about 6 weeks out, there was a flare reaction. Wait, watch, it was done, resolved by about 24 weeks. So no infections in those two. There was another Viadisc NP that had another flare reaction, resolved by about 24 weeks. And then in the study, I think there was one discitis treated with antibiotics, resolved by about 24 weeks. Dysgenics, 98 between the US study and 38 in the Japanese study. They've had no they've had no infections or no significant events like this. With discography, the risk of discitis is very low, but it's there. It's been reported, down in the 1.5%, sub 3% range. It'll show up about 1 to 14 days. And usually you're going to start seeing some sort of positive cultures in labs. And sometimes you got to treat it surgically. Sometimes you can get by with antibiotics. It just depends on how advanced and how aggressive it is. Next slide. So the summary is, anytime you're doing intradiscal injections, one plus cc's of injectate into a lumbar disc, that's when you start to create some pressure. Sub 1 cc, you're really not creating much pressure, so there won't be much pain. Anytime you start recreating pressure in the disc, that's going to recreate the pain because of stimulating the annulus and also potentially the end plates, and that'll cause some spasms. So lumbar corset, muscle relaxant, and then analgesic pain medication. Discitis can happen anywhere from 1 to 4% to avascular space. Treat with IV antibiotics before you're injecting. Use a 2-needle technique. One of the main things is if you start to have somebody with really increased axial low back pain after an intradiscal procedure, jump on it fast. Do not ignore this stuff. And get labs right away. Get a follow-up MRI. If you start to question what's going on, ask one of us. Reach out to one of us. We've seen a lot of this stuff now, and we're more than happy to consult and send us some images. And people that are sick look sick. People with discitis, there's a window of time where you just don't know what the hell's going on. And historically, before we were seeing these inflammatory motor changes, we would kind of reflexively jump at it and go, oh my gosh, this is infectious. But they're not always infectious. And so it's very important to use a sterile technique. As we inject certain things, there's transfer on the back table. You got to make sure that you're using sterile technique, fully drape the C-arm, gown up, do everything you can to the best of your ability to avoid exposure to any kind of infectious process during the procedure. Now, you can't control if somebody has something circulating in their blood or something that's seeded from a previous infection long ago, but at least you can be as diligent as possible during your procedure. The aseptics, you just watch and wait. Septic, sometimes I was biopsying to try to figure out whether it was or not. And when I did, I lavaged it. So I'm not saying that's absolutely the right way, but when we were trying to figure out what was going on, that was what I was doing consistently. Thank you.
Well, nice work, everybody. Good to be with you. I'm Doug Beal, radiologist from Oklahoma City. And it's I'm going to kind of hit almost the cleanup batter before Ramu's closing remarks. Let's go ahead and go on to the next slide. So we'll talk about the future landscape of intradiscal therapies. And one of the things that we really look forward to is the large variety of different therapeutics. Go to the next slide, please. And they range from all the way from things that have been talked about, such as hydrogels, to cellular therapy, both allogeneic and autologous. We have small molecule things that are very similar to the lactate that kind of dissolves the disc and treats for disc herniation. We have a large cohort of products that are going through the biologics licensing application, and we have a few that are currently on market. The ViDisc NP, as was mentioned, we have autologous from Regenix and Creative Medical, and these are bone marrow aspirate re-injected back in. And then we have expanded cell lines like biorestorative therapeutics. Next slide. And let me go over a few of these because Kaz hit the previous studies on this. I can go through the high points for you. So Temazimab is a monoclonal antibody that's anti-nerve growth factor. This has been studied, and the original phase 3 trial, it had an increased adverse event rate that should say increased adverse event with the 10 milligrams instead of the 5. It was in fact double. So it not only had increased complication and adverse event rate, but it did not attain statistical significance between low back pain and function using the Roland-Morris. Next slide. The next new product that's been studied was growth differentiating factor 5, GDF5, and this was the Johnson & Johnson product. Similar to Temazimab, it had increased adverse events. In fact, about half of the patients in the higher dose reported back pain. 46% reported low back pain as an adverse event. And of course, that's a very unpopular event. That was a non-starter, very difficult to enroll trial, and the sponsor elected to discontinue this. Next slide. Kaz went over previously the Mesoblast trial. I think the main thing about the Mesoblast trial that didn't attain statistical significance across the board was the fact that this had an amalgam. It had to have 50% pain reduction, the typical Oswestry disability decrease, and no additional interventions. And although it attained a statistical pain reduction of 1 year, and that's important because the phase 3B trial for this is going to have that as a primary endpoint, a pain reduction endpoint at 12 months, and then functional and opioid reduction as secondary endpoints. So it's very difficult to hit this kind of amalgam pain point, and this is a learning point for the Mesoblast trial. Next slide. A learning point for the Vibex trial, as was mentioned previously as well, is that saline is an active treatment. It's not a placebo. And so whenever we look at the Vibex trial, it attained statistical significance in terms of functional analysis and decreased the pain 15 points or more in the Oswestry. That was statistically significant and fairly well so, but it did not attain a pain reduction statistical significance. Only in the higher responder group of 20 points or more did it attain statistical significance because it had a 45% reduction in pain. And for you guys who are familiar with that type of pain reduction in terms of the placebos, even greater than some of the active treatment arms. For example, this was greater pain reduction than the basovertebral nerve ablation in the SMART trial. And so the next study is to take this through a BLA 351 pathway, biologics licensing application, and the next step is to do phase 3 trial. Next study, next slide. So the Dysgenics trial with ribonaputum cell, this was the name of the modified disc nucleus pulposus cell. This did attain statistical significance in terms of pain, function, quality of life, which was very nice that it did that, impressive that it did that. It also had about the same response level as some of the other cellular therapies. Did not have the same response therapy as some of the placebo or controlled trials, but it had optimal dose response, meaning the 9 million cells did better than the 3 million, and it had adequate safety, and it continued out to this study is now out at 78 weeks with still statistical significance. Next slide. The Spine Biopharma, the formerly known Remidisc, this is now known as SB01, in the phase 2B trial didn't attain statistical significance, primarily because the dose response curves wasn't paid too much attention to. The 3 and 6 millimeter doses did a lot better than the rest of them. Also, the study population was a little bit too broad. And so because of these important factors, the FDA gave them S&P, a study may proceed, and go on to the phase 3 trial, which is called the model trial. This is currently ongoing. And this is one of the things that we can target to look at a dose response curve of the 3 and 6 milligram doses and to offer separation between those two. Next slide. The different type of augmentation of the intervertebral disc is known as hydrofilm. This was discussed previously. So this is not a cellular therapy. It doesn't have any anti-inflammatory action. What this does is have structural support, and it probably, as Dr. Derby said previously, probably has some sort of a sealing effect on the annular tearing, which this is noted to do because this is sterilely impregnated with barium. It's also PVA and PVP. And in the Columbia trial, it had a 67 and 87% reduction in improvement in pain and function, respectively. And in the Canadian trial, which is Olivier Clerc is the primary investigator on this one, it has an 81 and 90% improvements in pain and function, which is highly impressive. Next slide. So to bring it back all together, a lot of these technologies are really green lighted. So Mesoblast is having another phase 3. Dysgenics, Spine Biopharma has an ongoing phase 3. BioRestorative is progressing on to phase 3. Fibrogenesis, Cybrocell is going on to a phase 3 trial. Stable, which is somewhat of a lactate derivative. This is designed to treat discogenic pain that really is manifested in terms of a disc herniation, radicular pain. And then, of course, we've discussed Regeltech and Hydrocell. And there's also important things known as other proteins. And then there's gene therapeutics. Gene Unique is not yet ongoing, but the process and the concept of being able to offer gene therapy is incredible, I think, at this point in time. Next slide. And so, in summary, what we've seen really is the cellular-based therapies are all about the same, and they all provide pain and functional improvements up to 70%, which is profound and very similar to the Wu meta-analysis done in spine in 2016, where all predicted that these would do very well. We have some of the autologous products that are being marketed today. We have Vitus NP, which is micronized disc material back into the disc. These are the 361 products. And then the Mesoblast, the Dysgenics, the regular Viadisc with cells, BioRestorative, and the Fibrogenesis product are all going through the biologics licensing application. This is the 351 products. And so hopefully they'll be out soon and be available because the results, as you've seen, are very impressive. The Remidisc, SB01, is a 7-amino acid anti-inflammatory pathway that has great possibilities if we can get the dose response curve correct and we can have the patient selection appropriate. And then Stace 363 is primarily used for disc herniations. And this is, I kind of think of this as the modern version of chymopapane. And I know that's a throwback product, but this is designed for acute radiculopathy with disc herniation. And then finally, the hydrogel provides structural support in addition to everything else. It's made out of PVA and PVP, and it bonds by hydrogen bonds. And you can break this thing apart in the lab on a repetitive stress machine. As long as it remains in an aqueous environment, it will self-heal. So it's a self-healing hydrogel. So in summary, a lot of this is very impressive. It's very interesting, and the future of intradiscal therapies is very bright. And so, in conclusion, I'm going to turn it back over to Ramo for some remarks.
Thanks so much, Doug. That was an awesome overview of the future. As I think everyone's learned tonight, doing the actual procedure, putting a needle into the disc is the easy part. You are now learning about all of these new therapies that are coming to market or soon might come to market. And really, we're going to have all of these at our disposal to choose from. What you learn about as well from Dr. Davis is some of the complications that can occur. It's important to do exactly what he says to mitigate those risks and to act quickly if you see them. But as long as you maintain your sterile technique, you're active, you're there for the patient, you shouldn't see any major issues. And it's really important, as he said, to communicate with those of us who have the experience. We're here for you to help out, and we can share our knowledge. And what Dr. Amir Delfin has highlighted and what I said PSPS is all about is the evidence. I think every company that is coming to market understands that we're not just going to accept taking a product and believing the theories about it. We need to see the evidence in our patients. And I'm glad to see there's heavy investment in that. And then, of course, last but certainly not least, Dr. Derby has given us a great overview of the last 50 years in intradiscal therapeutics. He talked about the roller coaster that we've been through. And the question is, now that we're on this upswing once again, are we going to continue to swing up, or are we going to see another downturn? And that really remains to be seen. And I'm hopeful that all of us will dive in, have an open mind, and be critical of the evidence that we see. Because really, in the end, if you fake it, our patients are the ones who suffer and we suffer. So we really need to understand the evidence and be scrupulous as we go through things moving forward. So I want to thank everybody who was on the webinar tonight. I can't imagine a better panel for this particular topic. and they will certainly be at our annual meeting in mid-September, and I'll have a slide about that in just a sec. So if you want to meet them in person and ask more questions, please come. The registration is free. You can't beat that, and it's in Las Vegas, not bad. I want to also thank all the sponsors again who contributed to this webinar. And again, it was really cool to see some of the stuff that's coming out. I just want to spend the last 15 seconds or so talking about our APP course. PSPS has certainly committed and invested in our advanced practice providers. There's a webinar series hosted by Dr. Dennis Patterson and Dr. Jackie Weisbein, and there will also be an APP track at our annual meeting on Friday, September 16th, again in Las Vegas. Next slide. And then this is your link to the annual meeting. I hope you will all join us. Our meeting is from September 16th through the 18th. As you can see here at the lovely Aria Hotel. We are super excited about this meeting. The agenda looks amazing. The unique thing about our society compared to all of the other societies out there is that we bring in a lot of spine surgeons. So this is a great opportunity to understand how spine surgeons look at things, and it's an opportunity for them to look at how we do things in interventional pain. And a lot of the challenging discussions and topics that have really come about in the last few years, this is the society to discuss those things. And we're really looking forward to the innovation and education at this particular meeting. We hope to see you there. And again, you can't beat a free registration. So the only thing you have to pay for really is a hotel and airfare. Bring the family, should be a lot of fun. And I hope you have a great night tonight. I hope you found this useful. Take care.